this Psychopharmacology Congress. It's our honor, and just for giving us the opportunity to make presentation in this. And I would like to congratulate the 20th year of the Psychopharmacology Association. And this is really an important congress to sustain the upcoming events. And also, I also have the honor and happiness to be making such a presentation accompanying Ms. Feza. And for 3 days, we have been talking about the different aspects, perspectives of the psychopharmacology, because in the last decade, there have been some bottlenecks in psychopharmacology. So how we can strengthen this psychopharmacological treatments, how new preparations could be added, and these have been put on the agenda. And in this Congress, there are in some of the 3 or 4 panels had the theme about AI, and we have seen that these have been on our agenda frequently. And what does artificial intelligence does? We aim to access to specific information specific to the people, patients, or to form a model specific to the patients. And I let we also listen to the presentations that these AI has a predictive may act as a predictive model, or bio indicators, or these voice analyzers, or face recognition. All different data convening together would help to create a treatment specific to a certain patient. Perhaps a personalized treatment is about, of course, the person's genetics. If we could take the genetics or include the genetics into this circle, in this cycle, in all these parameters, perhaps we would have an high predictive value data. And always in the clinic, we always have this drug that we prescribe, whether it would treat with whether treat our patient without any resistance, or would there be any side effects, whether there would be an interaction among the drugs, without knowing the answer with our classical evaluations, with the amino acids, and also with our sense of being a clinician, as well as with our experience. What we do, as mentioned before by Mr. Mesut, via trial and error, we are trying to see an side effect or not, and we prescribe the drug, and then we wait for it. How do we wait for that? For example, in order to make the decision whether this drug is efficacious or not, at least we have to use this drug at the maximum dose, so that we could say this is effective or not. Of course, there are studies done later to this, and accordingly, there are some financial as well as financial burden. But for depression, and then in 2018, there was a study carried out in the USA, and per person, for the resistant case, the cost is $17,590, and it means that annually there's a loss of 38.5 days loss labor force, and also, and it is 1.7 folds of the people who respond to this, and for the ones who don't have the major depression, it is they're 6.2 folds than the number of these major depression problems. And the people are in agony, and then they lose the life happiness, and also other aspects are problems, and the financial load is so high, and it is on our shoulders. So for that reason, and while we do the evaluation of these tests, and we can say that we come across a big financial load in front of us, and there are many variables and parameters that would influence the response to the treatment as well as the safety. And of course, the most important thing is the genetic interaction is very important. And at this point, to access to the information specific to the patient, and also the transcribing what the genes tell about the patient, because in some way genes talk to us. So for that reason, there are certain science branches, and pharmacokinetic is one of them. And what is our objective is to access to these specific information specific to the patient, and via the identification of the variants, for example. What do the studies tell us? And there are many meta-analyses conducted already and still ongoing. There are ongoing meta-analysis, and new variants are also being studied. And the results of these meta-analysis show us that the cases where pharmacogenetic genetic tests are carried out, we say that it requires by 30% less drug change, and then by 40% less adverse side effect, and 58% less hospitalization, 35% less application to the emergency department. And at the end of the day, pharmacokinetic and pharmacodynamic are evaluated, and we need some data to make the evaluation furthermore. And now let me go further beyond the practical information. So when we talk about the pharmacogenetic gene panel, we are talking about 11 genes. 6 of them are CIP enzyme system. They belong to the CIP enzyme system. And as I have just mentioned, most of them are CIP19, CIP2C19, and they are identified in terms of the metabolism through these genes. And as per these genes, there are certain variants as well. And as per the variants, pharmacokinetic puts forward a certain variant. For example, the one that is eliminated 2C19, which the drug that is administered with this gene, if there is a slow variant, then what happens is that there's probability that there is a rise in the blood that would go far beyond the therapeutic dose, and this would increase the toxicity. And via these genes, pharmacokinetic genes, what is our possibility? If the drug we're considering is 2C19 through, if it is metabolized via 2C19 or 2B6, if we have seen that this is the case in preparation, then we would apply different drugs. For example, fluoxetine, 2C9, with a different gene variation, it is metabolized. So for that reason, sertraline and escitalopram, and we knew that a different pathways used, and this forms a kind of option for us practically. And this is also valid for the antipsychotics, and also valid for the mood regulators. And also, let's look into the pharmacodynamic gene drug interactions. And here, in pharmacodynamic, we're talking about the side effects and as well as the response to the drug. And actually, the pharmacodynamic tests are not determinist, and it doesn't give us 100% result, but it talks about big high probability, and this is very important. Before we go for the try and ever, having such a map in hand certainly gives us a range of options. And here in pharmacodynamic genes, we have 15 genes here, and some of them are put forward the profile of the antidepressant, and some of them are related with the antipsychotics, and some of them are related with the mood regulators. And also some evaluations are about put forward the evaluations regard the side effects, and especially CLC6A4 and BDNF genes, especially in terms of the response to the SSRIs, they put forward, they bring up information, and also the COMPT gene activation. It gives us an information about the variation, and also second generation antipsychotic. One of the most important side effects is metabolic syndrome, for example, whether the drug is efficacious, however the patient is metabolic syndrome, and then we might lose the patient because of metabolic syndrome. And the schizophrenic patients, their survival, perhaps they neglect their self care. So for that reason, their survival is less by 10 or 15 years compared to the normal population. And some genes, as mentioned before, as denoted, HLA, HLA-B genes, and while we use the lamotrigine and carbamazepine, we really avoid, because we avoid the dermatitis, because if there is such a risk. And if it says that you have to be cautious, then you avoid this preparation, of course. HLA and AB and A and B. And there are many studies are ongoing about the on this. And you know the leukocyte antigen. This is a variant, HLA, A and B. And these genes, 3802 variant is being studied. And this is about the clozapine agonist risk. It has a value for this. So at the end of the day, if I would have such a test made, if HLA or AA and B, if there is a variance like that, and I wouldn't go for the clozapine, for example, this would be a sign for me. However, all the time, whether this doesn't mean that there is 100% a risk, but this is a sign for us, though. So, I have already explained these, and I don't want to bore you with the details now. Now, just through a patient of mine, a pharmacogenetic battery, what could give us and what do we share in the reports. And this is a 52 years old male patient. Intellectuality level is quite high. In the entrance exams to the university, he ranked the first, and he is in the field of finance. He is an high executive, and then in unipolar and repetitive depression, he had comorbidity, and then he was treated all the time, and then he never became melancholic or psychotic, and he never had the suicidal idea, and this was a depression and a common anxiety disorder. And for years, classically, and sertraline paroxetine was prescribed, and from amitriptyline and bupropion, aripiprazole, also augmentations were made. And then, however, the desired response never achieved. And then 4 years ago, he was diagnosed with Hodgkin lymphoma, and of course the scene or the picture worsened. And when he came to me, he had concerns with health because of Hodgkin's, of course, and he had the fear of being dismissed from the work, and he also had sleeplessness and also exhaustion, and he had a problem with his spouse, and he was always afraid to be abandoned, and but he had a high intellectually though, and he was using different six different types of drugs: escitalopram, mirtazapine, tulprit, lamotrigine, and whatever the group of this drug is, more or less he was prescribed with them. And since there was no response and augmentation was opted, and my colleague tried to be beneficial through polymorphism, and then he referred his patient to me whether we could do TMS, and then I thought that we should not stop the drugs all of a sudden, and I planned to increase the lamotrigine and then start planning applying TMS. The anxiety got decreased a bit, and but still he really had other problems still. And then I proposed him to have a pharmacokinetic test, and in these tests, first of all, in the reporting of these tests, pharmacokinetic and the genetic tests, we have the summary on the first page, and we see that there are 11 pharmacokinetic genes that are we see on the first page. And what do we see here? We see that CYP19 and CYP2C9, the phenotype is prominent. So here in 2C19, the drugs that are metabolized in this gene are to be paid attention, and there's probability that the blood level would be more than would be desired. And and when we look into the pharmacodynamic test, he used for a long period of time SSRIs with high dose and even exceeding the dose. But this patient is LCA 6A4 as per this variant, as per the SS variant, response to this SSRI is rather low, and also the probability of having high the risk for the side effect. We obtain this information. This is very important, and this patient has been using SSRIs for a long period of time, and perhaps because of the SSRI side effects, he has got high anxiety, and this might be overlooked, of course, from time to time. But this is a case that is resistant to the SSRI. And once again, in depression treatment, what we pay attention is that folate metabolism. We know that folic acid is used a lot in augmentation. Actually, perhaps we don't know most of the time why we use it, but within this panel, MTHFR gene, when there is a variant of this, the folate metabolism is low, then there is a gap of folic acid. And having the folic acid gap, it means that the antidepressant response would be reduced by 50%. So this denotes it, and it's really valuable in this respect. And our if this patient had schizophrenia or psychosis, he would be in the psychosis range, then we would look into the COMT. And in the MET variants, COMT means that collapse of the they are responsible for the dopamine collapse. And then in the MET variants, there is slow activation. And when there is slow activation, what does it? The prefrontal and frontal dopamine rises, and the one who has high prefrontal dopamine, the second generation antipsychotics would be responded high. So this is really important finding, and this might be just the reverse or the opposite, of course. And afterwards, all these antidepressants, pharmacokinetic interaction were listed down in detail, as you would pay attention, citalopram, escitalopram, and for sertraline, there has been a warning made because they are metabolized by C19 and 2C19 and slowly metabolized, and it gives a signaling, an alert, of course, alarm. It's alarming. And then the other tricyclic antidepressants, it also gives us information, and also for the mood stabilizers, it gives us information as well, and also antipsychotics. For example, in this patient, if this patient were an had psychosis or psychotic, then if we would use clozapine, then there is an induction risk for the caffeine or for smoking. And then it tells us that you should go for another preparation, olanzapine. And for clozapine, especially A1, if there's 1A2 gene, there's an indication for dosage. And most of the time, when we couldn't get a response to the case, we see that because of this, and we see it in the clinic. And also, all the enzymes, one by one, in detail, the results are to be shared with us. And here, and generally, I explained about these. And in this patient here, it tells us that. And this in the right corner up, you would see that SSRIs, so this patient does not respond to SSRIs, then you would consider it non-SSRI or SNRIs, or tricyclic antidepressant. And this is a really important data that is shared with us. And once again, folate replacement, in terms of folate replacement, it also warns us. And here, finally, just in a summary form, we have such a page like this. On the left side, as it goes on to the left side, it warns about these drugs on the left side. For example, in this patient, it is CP2 and 19 slowly to be metabolized when there's such a variant, citalopram, escitalopram, and sertraline should be paid attention, and it has given us a warning for this, and we have to pay attention to the SSRIs, and it says that you need to go away from these SSRIs, and as a standard option, it just lists these options, and sometimes on the right side, it says I absolutely recommend this, it says, and it provides a certain options like this. And what I did for this, I titrated doses and then I stopped it. And lastly, and I have the sertraline. And then I 150 milligram per day imipenem and alprazolam 1 milligram are prescribed. This is really an interesting and amazing result. And for 2 or 3 months, he always said that I'm not good in condition, or I've got anxiety, he said. Nothing has changed, he said. He has been telling this for 2 or 3 months, and after 150 milligram of per day imipramine, and I saw him after 3 weeks, and he said that I'm better. He gave the answer as I'm better. So saying that I'm better, of course, is really important for me. And of course, on the other hand, for 20 years, he could not be treated, and he always came confronted with resistance. He had a very low quality of life, almost at the point on the verge of losing the attachment with life. So when he says that I'm better, you can guess how happy we're when we're so beneficial for our patients, and this was really worth a lot. And of course, some of the preparations are important to be put on the agenda. It's also important in this regard because cyclic antidepressants were used while during my residence, and then SSRI came, and then we excluded this and cardiac side effects, and then for many other side effects in SSRIs for my patients that I am treating, pharmacokinetic and pharmacodynamic aspects. There are many data that have errors, so I'm not excluding the SSRIs. They're really valuable for us. The profile is low, but in our community, we should not underestimate the underestimate these results. And actually, we have to review this, and it's important. And in my another patient, and also with depression, and she got quetiapine, and she always gets analgesic, and she has panic disorder and phobic disorders, and then she didn't respond to the treatment, and most of the time she used the SSRIs. However, she always has a problem, and a problem of in the chest. She always had a tight chest, she mentioned. And then after a certain follow-up, I asked whether pharmacokinetic test and pharmacodynamic test and effector, as per the test results, because these tests referred us to the SSRIs, I prescribed 37.5 milligram Effexor, and then all of a sudden she said that now I'm in another dimension. I feel myself in another dimension. So that anxiety in the chest decreased on the second day, and this was the feedback. And still, she now continues with the 37.5 milligram of Effexor. And just similarly, 2D6 2D6, the slow variant was effective, and 2C9 variant was effective. And also, once again, similarly, sometimes in these tests, the European or Asian races, there are, of course, some different results, because it says that the Asian races should pay attention to this, and there might be an resistance if the patients from Europe, for example, or European, there might be some side effects very high, so there are such warnings. So the probability of low response to the SSRI. So what we have done, it denoted the SNRI, the test. So for that reason, we can consider SNRI, and then we went for that with a low dose, and then we could get the good result out of it. And it doesn't mean that we always would have the same result. So we should not go the evaluation fetishism. So we should have the pharmacokinetic tests and dynamic ones as well. We shall prescribe the drug, and then everything is okay. No, this is not the case, because the golden standard is the one-to-one relation, and also therapeutic response, and also to ensure the participation of the patient into the treatment. And just additionally, there are also important information provided, especially it tells us where we would start from. So finally, I think we're almost done. This is another patient who has been addicted to cocaine for 16 years. He was a very strictly resistant addicted, and then we hospitalized the patient, and we got an interesting result from this patient, and the SSRI usage denoted the gastrointestinal risk or the side effects. However, here there's a COMT variation and val variation. So the COMT activity is high, and so for that reason, prefrontal dopamine is low. This genetic panel told us so, and accordingly, there is a dopamine hunger is available, and he is addicted to cocaine as well as alcohol. And just as to complement the dopamine deficiency, he was taking the alcohol and as well as the cocaine. And what we did, we polyperidone was given, and treatment was given. Only with the polyperidone is prescribed, and for 1 year, no cocaine, no alcohol in his life. And at the end of the day, I also would like to share this case with you lastly. And as I have just mentioned, HLA 3101 variant, Steven Jensen's syndrome is indicated, denoted, and with a report that we came across that, and it said that carbamazepine should not be used. And I try to elaborate and tell without going too much into detail, but there are always subjects we always discuss about. And what are the pharmacogenetic tests that can help us? Still, we're studying them, and whether the drugs are metabolized rapidly or slowly, and also the blood levels. In order to achieve the blood levels, how we should behave, and in order to put forward the if, effect profile, how this panel helps us. If there is a dopamine deficiency, we can use transcranial tests, and if there is folate deficiency, it also warns us. In terms of Steven-Johnson syndrome, it also warns us. But one of the things that we are very curious that whether there would be the risk related to clozapine would be forward, and ataxia, for example, is aripiprazole. But akathisia, sometimes we are afraid of this. And then, and these are the information that I wanted to share with you. And thank you very much for your listening.